Welcome all of you to the 30th live webinar on orthopedic principles. This time we have Dr. Muralidharan as our faculty. Dr. Muralidharan is an academic, accomplished spine surgeon practicing in Apollo Hospitals, Chennai, India. He completed his FRC's trauma and orthopedics in UK and he worked for the NHS for a decade before beginning his practice in India. He completed his spine surgery training in the well-acclaimed spine unit at Queen's Medical Center, Nottingham, UK. He has a special talent for teaching and is involved in teaching spine surgery for the fellowship exam. Today, he's going to discuss a few topics relevant to spine surgery in relation to the fellowship exam. Over to you, Dr. Murali. You can share your screen.
Thanks, Hitesh. Can you see my screen now?
Yes.
Yes. Hi, and hello to everyone. Hope everyone is safe and well in these tough times. Today's session, I will focus on the spine topics that will pop up frequently. Before that, just a few minutes, I just want to reiterate that we know the famous quote that if you fail to prepare, then you're preparing to fail. It's a very famous quote. What does it mean? It means that planning is fundamental and key is to success is practice. So when I mean planning and preparation, so basically you have to plan, because see, this is the last exam of most of our lifetime, and after this exam, you're in a different world, different side of your career. So you have to plan. Are you prepared enough to sit for the exam? Have you done your all the rotation? Have you acquainted all the knowledge needed to sit for the exam, and you know the curriculum well, and you've done all your homework for that? And you also have to plan which is the right time. Have you done, is it you're going to do in the 4th year of the rotation or 5th year, beginning of 5th year of the rotation, or have you done 4 or 5 years of registrar experience and you're good enough to sit for the exam? So you have to plan it. And also the year, whether that year is suitable and you have any other commitments or anything. And because you need good 6 to 12 months, and it depends on the candidate. Some people are very sleek and smart and they need 6 months, and some people take 12 months between the part 1 and part 2, for the whole process. So when I mean preparation, it's basically you have to prepare. Okay, now I've planned it that I need to sit for the exam. I've done all the things, I'm ready. Then you have to prepare. When you mean prepare, you have to make sure you have some buddies pairing up with you from your training or from your rotation, or you have some through your network, you establish a group and you collect all the materials you needed, like study materials for part 1, part 2, and also all the courses, that essential courses you need to be doing and everything. And I mean, prioritize is when you're doing the exam, you got to make sure that you don't take up a very busy job, or you're involved in you take up some academic activities and everything. So put all your research and everything on the side, and also make sure you're not planned anything on that in your life side as well. And know your weakness, like with regards to curriculum, which areas you're weak. If you think you've not done a bit of pediatric orthopedics or spine, or you're not done one specialty, subspecialty, then try and do that specialty, or spend some time, in attending clinics and theaters with that specialty, and make sure you gain enough skills, because having too much on one and less on other may not help, because you will get caught somewhere. And then comes the practice. So once you've planned, once you've prepared, once you've group and started it, every day in your routine, in your outpatient clinic, you'll be doing a couple of outpatient clinic a week. In outpatient clinic, every patient you see as your exam patient and approach them, history taking, time them. Okay, you have to finish sleep in your history taking 5 minutes, examination, and then presenting it. Those things you can practice. Every patient you see from the day you plan for exam, once you've done your part 1 and ready for part 2, you make sure you practice every patient as your exam patient, and then that's it. Once you've done all these homework, you're going to perform on the day. And believe me, if you've done your homework and you practice and everything, you prepared. And a lot of people say it is a stressful exam, very nervous, very difficult and everything. But if you prepared well and you think ready and you prepared, then it's a very predictable exam. Believe me, path is very predictable and you will just fly through all the stations. So today's session is focusing about spine that's going to pop up and how you deal with the spine in clinico-vivo stations. See, the spine is one area where even from my days and most of the time trainees and registrar they shy away. They say I'm good in everything. I just pray that I don't want any spine topics. But sadly, if you look at the the overall questions, whether it be part 1 or it be part 2 Y1 clinicals, 20% is almost spine topics. So there's no excuse to be not gain knowledge or shying away from it. So spine as such can pop up in your Viva stations, anywhere in your Viva stations. Can come in a basic science like a disc or a spinal cord cross-section anatomy. In a trauma, you can get a cervical trauma or a Thracolumbar trauma. In adult pathology, you can get a slip disc, degenerative disc. You can get a cardiac vena. You can get infection tumor in deformity. In pediatrics, you can get a scoliosis topic or a cerebral palsy with scoliosis to discuss, Sherman's kyphosis. So why there's no way you think you got away without in basic science or trauma. It may pop up here and there anywhere. And same as examination, in intermediate case, you have 2 cases and there is a high chance that you can get one either with a cervical, for example, cervical malleus cervical examination or scoliosis or kyphosis or a simple, back pain examination. In a short case as well, you can get a couple of, examinations to demonstrate like Adams in a scoliosis patient to demonstrate Adams forward twin-test, or you can get a foot drop patient with a slip disc. So there are all the ways throughout your stations for you to get spine topic. So what we aim through this is to prepare you, give you gist of what needed for the exam, and so that you will be comfortable in approaching all these stations. As I said, when you approach a Viva station, the key thing is what examiners are looking for. The examiners are looking for you for a safe, confident colleague who is day 1 consultant. So they're looking for a colleague. They're not looking for you to fail. So they're looking for a colleague. So whenever you approach a station, make sure that you are to their par and approach the station with confidence. And at the same time, whenever the Viva is going to start with a flashcard. So when you get a flashcard, before you spit out, compose your thoughts and make sure that this is what I'm going to tell, relevant things, and then take a lead from then on. So as you know, most of the Viva is going to start with a flashcard and an open-ended question. So we'll start our today's with a spine trauma. So you will be shown a flashcard and an X-ray radiograph. So either they will say just what do you see or a comment about it, or they may give a scenario behind it, like somebody had a road traffic collision or something, and then this is the X-ray. So whenever I approach the radiograph, so you describe what you see anteroposterior and lateral radiograph, and describe there is a compression fracture, and then what you see in the AP, I see interpedicular widening at L1. So that points me that interpedicular widening and a fracture compression. So there's a fracture of the L1. So when you say interpedicular widening, then the examiner knows that's a buzzword. So you're thinking in terms of a burst fracture. So the examiner knows, okay, so you are everywhere throughout the stations, you have to give the buzzwords that they need and then take a lead from them. So once you picked it up, there is a Thracolumbar fracture. And the next thing is how you take control of it. So said, having seen the radiograph, it has got a Thracolumbar fracture. I would like to know more history. So you need a more history. And then they will give you a history, or they would have already said, this is a patient come in with a motorbike collision and this is the injury. So whatever it is, In a cervical trauma patient, the principles are the same. Going back to your principles, like advanced trauma life support. So you have to say that, the assume ATLS is done, life-threatening injuries are ruled out, and patient is hemodynamically stable, and this is the isolated injury. Then they will give you a lead and other things. So once you establish that this is where you start, so they know that you're going in a safe mode. So you said ATLS, life-threatening injuries, and everything. Then there comes how you move on further for the higher marks. Like from 5 you come to 6, and then 6 to 7, and 7 to 8. That's how you have to lead them on. So you said ATLS and life-threatening injuries, the buzzword, and they know. And then they're going to tell you that, no, doctor, this is isolated injury, and this is, so what's going on in your mind? So you think it's a Thracolumbar trauma, compression and lateral X-ray, and interpedicular widening. So it is a flexion compression type, but I'm not sure whether there is any distraction at the back or it's a burst fracture. So then you may, what is your next line? And you may say, would like a CT, that, because most of the time now the trauma, they get a pan CT, so you will be complemented with it. So they will be showing some CT, where you can see here on the CT sagittal, you can see a posterior superior fragment retrofulsing into the canal, and the axial as well, you can see canal occupancy and a multi-fragment vertebral body. So it's a burst fracture. So you're going to say it's a burst fracture. So now comes your depth knowledge about the management. So what you need to know is, you need to know the BOST guidelines. Okay, what is the BOST guideline for spine clearance and BOST guidelines for traumatic spine clearance? So once you've done, identified the injury and you describe the injury, and then what is going to be important is how you're going to manage this patient. So management is basically how you practice in a day-to-day life, whether you are in a DGH or in a tertiary center. The management is the same to start with. So as soon as you've seen the patient, life-threatening injury has been ruled out, you then move on to assess the neurology. So neurology is basically you have to spit out I will fill in a Asia chart. So the American Spinal Cord Injury Association chart is where universally followed. So every spinal patient has to be assessed for peripheral nerves and all the injuries, and the chart has to be filled in at the time of presentation, and then sequentially, every regular intervals. So that's what you got to say. I will fill in a Asia chart, and from there, what is important in a spine trauma, we have to make sure whether he has a neurology or not. And when you do the Asia chart, you will know whether the patient has got any neurological deficit. If there is it an incomplete spinal cord or it's a complete spinal cord injury? So whether it's a complete or incomplete injury, you will establish. So then they may ask you about spinal cord syndromes from there, if they want to take you, because most of the time spinal cord syndromes will be dealt in basic science order path. If they want, they can take you. Basically, what is the importance? Incomplete is has some prognosis to recover. So the management is all expedited, and there is some evidence, we do ultra early proceed surgeries and everything. Complete means it shows the density of the injury, and the likelihood of recovery is less compared to someone with incomplete injury. So you've done an Asia chart and you've established it's a complete or incomplete. And some of the examiners are keen to know whether you're aware of thoracolumbar fracture classification. So they may ask you, okay, you said it's a burst fracture, and how do you classify them? Any classification? See, the examiners love to know classification. If you're not sure of it, there's no harm in it, because it is, it's a brownie, but basic classifications you need to know. So when it comes to fracture classification, thoracolumbar fracture classification, the ones they would love to hear is a Denis, and it's based on 3-column injury, where your anterior column is the anterior half of the body and the annulus, and you got a middle column, posterior half of the body and the annulus, PLL, and then you are a third column, which is the posterior column, which is basically your posterior elements and your posterior ligamentous complex, which is your supraspinatus, interspinatus, facet capsule and flavum and everything. So that comes your posterior column. So your anterior column, middle column, three and a posterior column. What Denis proposed is, if two columns are injured, then it's unstable. If one column is injured, like a flexion compression, just a wedge fracture, you're safe. That's a stable. So this is what the principle, and this is what they love to hear. So you have to identify whether the injury is a stable or unstable. Whether whichever classification you're using, where you have to say whether it is stable or unstable, and why do you say it, and through which classification, Denis. And we all know AO classification as well. So A has got a flexion compression type, which is A types, and B is a flexion distraction injuries, and that's where you get a bony chance or soft tissue chance, and C is a severe form. So as you go in the order A, B, C, the severity increases. So C is a translation shear rotational fracture dislocation. It is a yes, very severe form of injury. So A, B, C, and you need to know the subtypes. And the other classification which has come up recently in the last decade is Thracolumbar injury classification system by Vaccaro group. And this is the only system which is point based, taking morphology, neurological status, and posterior ligamentous complex integrity. So this is your Denis, and Evo you will see, and I'm sure most of you would be aware of it. It's worth knowing the classification. And the tailings. So morphology is given few points based on the whether it's compression, burst, or translocation, or rotational, and integrity of PL, posterior ligamentous complex, is given a point based whether it's intact or suspected or injured. This is basically the posterior ligamentous complex is assessed in MRI, and MRI will show eye signal in the supraspinalis, interspinalis, ligamentum, facet capsule, everything. That indicates that your posterior tension band is disrupted. So that is MRI is used. Sometimes in a plain radiograph where there is this extensive interspinal widening, you don't need an MRI, it's off. So we know that. And then neurological status, how do you assess? Again, you do your HHR, and then you, whether it's intact, a nerve root, or complete or incomplete. You see your complete takes a score of 2 and incomplete takes a score of 3, because the incomplete is given more weightage because you want to act, you want to do surgically help do something, decompress, stabilize, give a chance for the recovery. So that's why an incomplete is given more than a complete. So you can see if the score is 4, it's intermediate, dealer choice. If it's more than 4, surgical, less than 4 is non-surgical. It's based on that. So the knowing classifications is good. And if you spit that out, and they know that you know you're good sound knowledge on the topic, and they love to move forward to you to brownie points with more. So once you've seen the classification, and examiners of keen to know, so what do you think, how did this injury, what is the mechanism of failure? So again, going back, you will have to have a good knowledge about the injury. So once you have asked him, if he said is fall from height, it's a compression, so you're going to axial compression, and you may end up in having a burst vertebra, so which is a burst fracture, flexion compression, once you fall from height. Or if you are thrown from a bike, then you can have a flexion and a distraction type, or like a seat belt injuries, flexion chance type. And if you have a roller coaster and you get a rotational injury, multiple rotation translates here, and you end up in a fracture dislocation. So the anterior column and middle column usually fails in a compression mode. So that's what they would want to hear, compression mode. Your posterior column fails in, it's a tension band. So it fails in a distraction mode, tension. So the distraction, so flexion distraction, where a chance you get it. So that's how it fails. So these things help you to get more brownie points, and so we have covered how do you approach HHR, whether it's establishing complete or incomplete is important, and whether it is what type of fracture class, what type of stable or unstable, and how did the column fail is good. And now coming to the management, you need to know certain principles. I'm sure by this time you all would have had lots of experience on the spine trauma management, receiving them in the emergency and managing them over the night, or at your DGH, or referring to tertiary centers. So basically, once you have established that the patient, here the examiners will give you more guide. Okay, so you want to know the HR. Once you spit out HR chart and I want to know the neurology, they will tell you that normal neurology. So now you're in they may take you to different ways. Okay, first, okay, so normal neurology, doctor, what do you want to do? So if it's normal neurology, then it's a burst fracture or a chance fracture. It's unstable. Once you establish the unstable fracture, neurologically intact, then your role is going to be, I would want to manage. If it's stable, you can manage with a brace, but if it's unstable, then stabilization is what are recommended, is practiced, because it helps them to recover and rehabilitate quicker. So now they may lead. This is a patient with a stable injury and no neurology. So we talked about stable, no neurology, but a burst fracture, and we talked about stabilization. Now comes the role. See, whether do you want, what is the role of MRI? So you established CT scan, you established it is a burst fracture, and neurology is normal. And comes the role of MRI. If it is a burst fracture, normal neurology, and if you're managing it conservatively with a brace, then MRI is not a mandate. But if you're planning for a surgery, it's good to know the status of the cord, the corners and everything. So I would get an MRI. And also it helps to assess the posterior ligamentous complex. So as a part of your scoring system, so they will push. The patient has not got a neurology, what an MRI is going to do. So you can say, I want to know the status of the cord corners, and also I want to see the status of the posterior ligamentous complex, because that will change your scoring and may say it is unstable, or may guide you for the management. So the role of MRI is to assess the posterior ligament integrity and also assess the cord and the neural structures. So the first scenario is burst fracture, no neurology. How do you approach? The management is, they will show you again and again, look, the fragment is retropulsed and the 80% canal is occupied and is a young chap. What do you want to do? Do you want to, how do you approach it? The manager, as I said, stabilization is recommended. But the question is, the catch is, would you decompress? Would you do the canal clearance? Will you clear that? It's all tempting to decompress. But what the evidence is? So this is, we are talking about is a normal neurology. So the evidence that you need to spit out is Voyager. Does canal clearance affect neurological outcome after thoracolumbar burst fracture? So this is the one you have to spit out. So what basically is their observation from their experience and meta-analysis, a seminal article every examiner want to hear. Even in a patient with a burst fracture with a neurological deficit, the concept of canal clearance is a belief, but you've seen a mechanical compression and you want to relieve it, and if you relieve it, you think it may help enhance or help to recover the neurology over time, but that is not the case. So what they've said is, whether you whether you clear or not, there's no difference, and canal clearance is not needed, and the injury happens at the primarily. So the decompression, subsequent decompression does not favor, and in terms you notice more complications in the group that are decompression. So the take home message is, if you have 80% canal compromise, retropulse fragment and neurological deficit, the evidence is does not need canal decompression. Clearance, stabilization is what sufficient. So going back to our question, the examiners may again pull you on again and again. So 80% young chap, what do you want to do? It's normal neurology. It's normal neurology. I'm not worried. Just stabilize. It will consolidate, resolve, and you'll be okay. And then they may say, oh, doctor, he's mobilizing. Now is developing neurology. Or they may give you a scenario from the beginning that he has a neurology. So in that case as well, you can say, if he is initially normal neurology, you can as such stick to your guns, say that the evidence is this, and I would explain to the patient and I will monitor him. But if he was normal, and if he is normal before but is developing on mobilization, means it's very unstable. So you, with the stabilization should be fine. But if you have mobilized him with a brace and it is not sufficient, then you have to take him to theater for a stabilization and a decompression at that stage, because he is normal but neurology is worsening, so you may help him to recover. So not all canal occupying fragments need to be decompressed as per the evidence. So they may also ask whether if they have an incomplete neurology or complete neurology, do you want to give steroids to help them recover? Yes, there was a once it was popular from Nazi's trial, methylprednisolone, but there was a lot of flaws and more adverse effects rather than beneficial effect. So the practice of methylprednisolone has faded away, and especially in European, in the UK setup, NHS setup, if you look at BOST and guidelines, NICE guidelines, there is no role of steroids in spinal cord injury. The only role of steroid in a spinal cord area is metastatic spinal cord compression. That's the only area where steroid is beneficial. So just keep that in mind. In a trauma setting, steroids no role. And we discussed about the role of decompression. And so that is it. So as soon as you approach, this is a patient ATLS, hemodynamic stability, Asia chart, BOST guidelines, NICE spine clearance guidelines, and fracture classification, and how does the column fail, and how do you manage the role of MRI, is basically to identify whether the posterior ligamental complex injury intact. Even if the patient is neurologically intact, it helps to guide your treatment based on the to assess the stability as well, based on the Telix classification, and the steroids and the decompression. And decompression seminal paper, you all had to know, spit out. And also one more thing I just want to highlight, if you look at our guidelines, so though nowadays we get more of a pan CT, sometimes if you have a patient with just a cervical spine clearance and thoracic and lumbar spine will be left for clinical examination and a subsequent radiographs. That's how the guideline also says. But what we found is clinical examination sensitivity specificity is very poor, and there is a very high chance you can miss 1 and 2 unstable fractures in a setting of trauma where there is a lot of distraction injuries. So good practice is whole spine CT. So most of the time now we are supplemented with, if not, keep in mind clinical examination is not that reliable to rule out a thoracolumbar fracture in a polytrauma patient. There is one more classification, the McCormack classification, but it is way beyond. You have to remember that in your station, the person asking a spine topic may not be a spine surgeon, and you may be a general orthopod, and you sometimes may have more knowledge than him, and you may be updated with him because you may not be practicing spine. You may be a hand surgeon or a knee surgeon. So it's always good if you try to give them few more, points, few more updates, and they will be, and if they think that you are, too good, and it will help you to get more scores. Sometimes, one station may not be like other, and it will help you to, gain points in the common topics. So common topics is where you can score maximum, brownies, and you can compensate for. There will be one or two stations where everyone would come with a with a topic or something. You may not be happy, but the common topics you can go bang on, and you can give more and more points, and you can compensate. There are so many areas, stations where you can compensate. So one of these is McCormack classification is basically load sharing classification, and also based on point system, and it helps to decide whether you need anterior reconstruction or not, whether posterior stabilization alone is sufficient or not. So it's based on the comminution of the vertebral body, and based on the displacement, and also based on how much kyphosis is angle. So that's how. So based on the scoring, if the scoring is low, you can, if the scoring is less than 7 or something, you can just stabilize posteriorly, and the vertebral body will heal and consolidate. If the score is high, then your posterior stabilization may fail and will need anterior support. So this will be taking you to 7, 8. So if you know McCormack classification and the principles, will give you more brownie points. So I said stable and unstable is what you need to differentiate, and if it is unstable, also they may question sometimes what is instability or something. Punjabi instability. How do you assess instability, unstable spine in a clinical situation? And you decide to manage that patient conservatively, or patient does not want surgery, then what you do option is brace and then sit them up. If you sit them up, if they are not able to tolerate the pain because of weight going through an injured part, and it's not able to take your weight, tolerate, and if he has pain, or if it develops any neurology, which means the fracture zone is not stable, and there is a movement displacement happening, compromising neural structure, and that's how you assess clinically the instability or unstable nature of the spine. If you elect to do a conservative, or patient choose to conservative, you put them on gauze, and you do this test before you commence them on mobilization to see whether the inherent stability. And also radiography, some of them use the how much kyphosis is less than more than 50% body is involved, kyphosis angle of 22 degrees, or displacement of 2 or 3. These are olden ways, but the more way to decide unstable is what we the classifications that we have discussed before. So there are, as I said, timing of surgery in a spinal cord injury. If the patient has got a spinal cord injury, the timing is still there is no consensus, and less than 24 hours, more than 24 to 48, more than 48. Now this is meta-analysis which gives some idea. There are plenty of papers, and you can choose one paper to keep in mind to quote. The basic consensus now is the more trend is towards do a early decompression, especially in an incomplete and also in a complete as well to give some chance. And people are moving from 24 within 24, and some people are going whether it's ultra early, which is less than 8 hours, gives the max. We know the neural structures, the potential recovery of all the neural structures is good if if it's done something 6 hours, 8 hours from the all the lab studies and animal studies and everything. So the trend is it yearly, which is 24 a bit, or it's ultra early, which is less than 24 hours, less than 8 hours. Sorry, ultra early is less than 28 hours, and yearly is 24 hours, and 24 to 48 more than 48 delayed. So some it depends which paper you look at it. You may find that there's no evidence. You may find that there's no difference. You may find difference. But general consensus now is that going early decompression in spinal cord injuries and early stabilization, decompression and stabilization. As I said, currently it is worth remembering this and quoting if you come across this kind of questions and timing. It's a spinal cord injury poem, which is a prospective observational European multi-center study, is currently underway to assess the efficacy of surgical decompression, acute surgical decompression in traumatic, whether it's Thracolumbar or cervical. This is similar to our other studies like the Proffer, Ames, Swift, Drift. It's a multi-center European-based big one, and we hope this to shed some light. So, if you're aware and if you remember and if you tend to do it, there's no consensus. And the current recommendation, the trend is this, but we're waiting for the European multi-center study, poem study. The examiner will be impressed, and you will get more brownie points. So as I said, burst fracture. So then they may ask, okay, so how do you? So if you are taking you to a stage of how do you, what do you want to do? Stabilization and that, then means you're well beyond your 6. And you'll be, now pushing. They will be pushing you for 7 to 8 and all. So burst fracture, as I said, we know that canal clearance is not needed. There's no evidence, and all the evidence we have is it resolve and remodel, and doesn't make difference to neurology. So now your burst fracture, how would you fix it? I would do a stabilization. Stabilization means you can do a short segment where one vertebra above, one vertebra below, or you can do a 2 above, 2 below, which is a long segment. This is traditionally they used to do. But now for a burst fracture, there is a consensus that mono segment has no difference in terms of outcomes compared to long segment. So mono segment, and also there is a along with monosegment, you can add a screw to the fractured vertebra, the index vertebra, and you have to study that in a pedicle. If the pedicle is everything fine, and you can use a additional support, structural support. So it's a short segment or a long segment. If the bones are osteopenic, a little bit elder, then or rotational injury, fracture dislocation, then 2 above, 2 below is the general practice. In a young adult, good bone, a burst fracture kind of one, or a chance fracture, then short segment is a good option. And as I said, there is no difference, so it becomes ultimately patient profile and what is your preference. And also there is no evidence about whether you're doing it open or minimally. So the long-term outcome is all same. Yes, the early blood loss and pain and hospital stay may be less, may favor MIS, and particularly in a polytrauma patient, this less invasiveness may help. Otherwise, there is no superiority in terms of long-term outcome. So open or MIS, no choice, and you pick one, whatever is comfortable, you stick to it. Same as a short or long, and depending on patient profile. So here are some of the ones where you just have a superior end plate fracture. There is no canal clearance. The posterior cortex is intact. Inferior end plate is intact. It's a very stable flexion, flexion compression, very stable. Then you have a retropulsion. It's coming in superior, posterior superior, and you also see in the coronal the only superior end plate is involved, the wall is also involved, the inferior end plate is involved, and the posterior wall is involved. So it's both end plates, both anterior posterior wall. So it is a complete burst fracture. That's what they call it as complete burst, incomplete or complete. And this is a chance fracture. You could see fracture going through the vertebral body, flexion distraction, and is opening up at the back. So it's a bony chance, seatbelt injuries. And you also see the interspinous widening and the sagittal. That's all telltale signs to say it's a flexion distraction injury. So they may show this CT, or this X-ray. You see, so there's a transosseous fracture through the vertebral body, and it's exiting out through the posterior elements, and there's interspinous opening, and it's suggesting a flexion distraction kind of injury. Then it all add to your Brownie point. Here the bones are fine, but it's a ligamentous. It's gone through the disc and it's come out of the. It's the energy has come out posteriorly, rupturing the posterior ligamentous complex, disturbing. So this is a ligamentous. This is what the MRI helps. In a stir sequence, you can see the eye signal in the interspinous, facet, ligamentum flavum, all area. So this is what the PLC, where the Telix scoring helps you, and MRI is playing a role in identifying whether the post. For these kind of ones, you don't need an MRI because this is very clear that you know that for sure that's going to be disrupted. It's only supplementing that. But in a burst injuries where you think there's a flexion, but we're not sure whether there's a distraction, it's only flexion, compression, or distraction, and that's where MRI is going to add on. And then you will see the translational injuries on the other one. There's no doubt, it's a fracture dislocation. Right. I think we've covered what we need to know. If anything, I'm sure you can put it in the chat box, and we'll try to address at the end of the session. The other one is cervical trauma. So there you go. You may be shown a radiograph, lateral radiograph. The far left shows, for me, it shows a lateral radiograph. The obvious finding is C5 subluxation over C6, almost 50% subluxation. So indicating it's a bifacial dislocation. But I'm only seeing a C7. I'm not seeing a T1. So C7 T1 junction is not seen. So the moment you say that, they're aware that you think this is inadequate. So you picked up a dislocation, bilateral dislocation, 50% subluxation, bilateral dislocation, but you also put the buzzword, it's an incomplete radiograph, because we know that 10 to 20% there is a chance spinal column they may have a fracture somewhere else. It could be C7 C1. The missed injury is more common in C7 C1, or it could be in somewhere down. So you said I want to see C7 T1. It's inadequate image, and that the first question from 5 you'll be taking into the next level. So you're safe, and then you lead it out. Okay. So I got a bifacial dislocation. I put in another one. It's the middle one, which shows a less than 25% subluxation and interspinous widening. You can see. So it is a unilateral facet dislocation. So you now is a unilateral or a bilateral dislocation, and they know that okay, you're talking sense, and about you manage these and you've seen it. See, that's what they're assessing in every station. How you take the lead, how you approach is means that they know that you have been in this situation before, you've dealt with it, and you're confident. So that's what you're trying to establish. Sometimes if you expect them to give a prompts, that means you're not moving forward. So that's right. So you've said I've seen is inadequate radiograph. It's a 5-6 dislocation. I want to know more history, and they would have already given you the history. So you have to assume if they once you've seen that, they may say that just what you see. Then you say 5-6 incomplete, and assuming this is a high energy injury, I would like to know the mechanism. Assuming ATLS is done, and I would like a CT as per BOST spine clearance guideline. Now you bring up your BOST guideline. wherever you can, whatever you bring in, they know, okay, you're talking more relevantly. And the Bose spine guideline says for a spine clearance, you need to have 2 to 3 millimeter slice sections that you have to spit out. So this is inadequate radiograph, but anyway, it looks, it's a high energy injury, and I would want to see the CT spine, and as per the Bose guideline, the CT should be 2 to 3 slice, and normally that comes with the pan CT, as a complement of the pan CT. I want to see the pan CT. I want to rule out any cervical thoracic junction. I want to see what is it, and then they will say, okay, fine. And then now you go to the same blah blah blah. Assuming ATLS is done, patient is life-threatening injury is ruled out and stable hemodynamically. Yes, and they may say yes. If they say that patient has come off a car collision, ATLS is safe, done, and it is the only injury, then don't go and say again the blah blah, waste your time. So I've seen the radiograph, it's inadequate. If ATLS is done, I would like to see the pan CT. So you're telling you're giving a clue that I've caught whatever you've said, and they know that you're with the situation and you're not asking again and again, you're going back. So you tell them, okay, so C5, C6 dislocation, high energy, and you said the ATLS is stable. I would like to now see the pan CT, and then they will give you the CT. So here I just want to highlight, we all know the A, B, Z's of the radiographs. Okay, any radiograph, you know how to read it. So the same as applies to the cervical. So look for alignments, look for bony contours, look for soft tissues, look for the 3 important lines: anterior vertebral line, posterior vertebral line, and a spinal laminar line. Some people draw a line on facets as well. So see whether it is, whether any malalignment. And also, about the soft tissues. Some examiners may like to know what is, how you read it. Okay. So the soft tissue contours, the way I remember is soft tissue abnormalities. At a C2, it should be less than 6 millimeter. At a C6 vertebra, it should be less than 20 millimeter, 2 centimeters, less than that. Whichever numbers you remember, whichever way you remember, that remember it. So they may know. And it's very rare that we will be, because by the time we will be asked about next is the Canadian C spine rule, because it's all more of emergency, and we don't get, because those are the criteria to rule out cervical spine injuries based on clinical examination. So if the patient has got no tenderness, no distraction injuries, clinically they can rule it out. But if there is any suspicion, that's where they do a for C spine. So the next is in Canadian. You just be aware, because I'm sure you all know it's all there in the ED, and it's all to emergency physicians. It's their area, and we don't do a clinical clearance. Very in a polytrauma, yes, we'll do the radiological as well as clinical clearance, but most of the time in an exam scenario, it will be more of a interesting topics, common topics, along with some examiners might want to know whether aware of it. So just be aware of that, because those are all clinical clearance of the cervical spine in a low energy, not in a high energy. Remember that. So good. So again, so you got a bifascial dislocation, and what do you want to? So as you see in the X-ray, and you see that I need to see the CT, so it's got a bifascial dislocation and no other injuries. Then I would like to do assess the neurology. I will put a Asia chart and ascertain whether the patient has got any root level injury or a cord level injury. If it's a cord, if it's a complete or an incomplete injury. So these are the words. The moment you say yes, you're not waiting for a prompt. So I would document that. Once I've done the assessment, I will document the Asia chart and I'll ascertain the neurology. And if the patient has got a spinal cord injury, and what you need to remember is, so we'll maintain the spinal precautions in a collar, inline mobilization. And what you need to do is, you need to alert. Here comes, from there as well, here as well. See, everywhere, once you've done your basic assessment and established it, they will say, how are you going to manage? You're going to say, first thing I'm going to speak is my specialist. So you're going to say, I will speak to my spine colleague, discuss, spine, I'll speak to my spine colleague, or I'll speak to the connected spinal cord injury unit. Or if you're in a DGH, you don't have spinal service, speak to the nearest, tertiary care center, which provides your spinal service for your institute. So that's the word. Buzzword is spinal expert. So I will refer it to the spinal team, spinal surgeon, involve the specialist and discuss with the appropriate unit. So those are the things they are looking for. If you've said ACHR, documentation, ascertaining the neurology, and discussing with the spinal surgeon or a spine unit or a spinal cord injury unit and those guidelines, then you're safe. You on your 6 already. Okay, then comes here the ones which is going to take you to more. Then you have to ascertain that you see in UK, every spinal cord injury patient, which wherever it is, whether it's a DGF or NHS, most of those who are practicing there, you have to refer or register the case to the network connected spinal cord injury center within 4 hours of presentation to your ED. So there is an online database, and that's where there is a spinal cord injury database where you do the referral, and from there on the spinal cord injury unit will give you the guidance, and you'll act accordingly. So that is the word you would have to use, buzzword. I will do a referral. Once I've done the assessmentation, documentation, I will speak to the spinal unit or will speak to the tertiary referral spinal service center, and if there is a spinal cord injury, whether it's complete or incomplete, you will notify and refer it to the spinal cord injury center, and you will fill in a you will fill in a spinal cord injury referral database. Okay, and then they will say, fine, okay, you are in the spine unit or you are the spine surgeon, how do you want to do? This is how it goes. Next, now you want to ascertain, so what are you going to do, doctor? This is 10 o'clock, this is 5 o'clock, he's a young chap, he has got a neurology. So now you say there is no, now they give you a lot of scenarios. Okay, so now from here it is how you lead as well. They will give you, they will want to pull you some way, but you can take a lead some way. So once you have done the referral, then I would like to know whether the patient is awake, alert, and oriented, or is the patient is uptended. So uptended is the word you use, whether it's they're intoxicated or drowsy or some other reasons. Is the patient alert, awake, and oriented, so that he's cooperating with his examination to ascertain the neurology, what you have done, what you assessed is you happy, or is not cooperating and is difficult to ascertain. So that's all you have to make sure. So it's awake patient, situation scenario management changes slightly, and an uptended patient it changes because difficult to assess. You have to assume there is a spinal cord injury until otherwise proven. So that is a key thing. So alert patient, whatever your assessment is, you are happy with it. There is injury, there is a deficit, there is incomplete or a complete, you're happy, you document it. If the patient is uptended, for whether he has a head injury or intoxicated or some other reasons, and you think it's not reliable, then assume the patient is quadriplegic or patient has neurology until otherwise proven. So here is what you need: MRI. So there comes the role of MRI. Then, so the MRI, and then you consider. So usually with DAGS, you don't have, you follow the instructions of the spinal center, spinal unit from a from your tertiary care center, and then deport the patient. That is the real life treatment. But exam, they say, okay, fine, you are in this, you are in the spinal unit and you are the spine team, and you got an MRI. So if the patient is uptended, MRI, and then you management. If the patient is awake, and you rely on the patient, then comes what you do. You're receiving at 7 o'clock in the evening, 8 o'clock in the evening. Then there comes the role even in awake and a cooperative patient with the neurology intact. You can do a awake reduction. This can be done safely in the ward or safely in the theater. Awake reduction, and you don't need an MRI for this. The timing varies. They may push. Do you want an MRI? Generally, no. In an awake alert patient, intact ward, you want to try to reduce it sooner. So you can apply a halo, bedside halo, and now they may ask you about halo applications, and these are all extra points. You already passed your past 6. You going for the more. So know about a halo pins, where you put front pins, side pins, and everything. Because once you put a halo, it gives a like a steering control, where you put a gentle traction and a slight rotation, probably it will reduce. So awake patient whom you think you're cooperative, you do a reduction. Awake reduction sooner, either in the ward if your unit protocol is, or take him to the theater and do awake reduction with a CM guidance. But these reductions takes time. These take time, and once you've done, some people reduce, put a halo, and they leave it in a traction. The patient is tolerating, neurology is okay. They put it in a bedside halo, weight traction, and start with the minimal, and then slowly add on. The skull probably 5 kg, and then each vertebra 1 or 2, 1 kg for each vertebra. So maximum, you calculate how much. So you start with minimal and slowly add on. Add on slowly, and every time you add on, you do the measurement. You assess the neurology, and then, and if the neurology is all same, you do a radiograph, bedside radiograph, and see whether how much is traction. I have been in the position and sat even throughout the night, where we're waiting for the gradual reduction to happen. It doesn't happen instantly, it happens gradually. Okay. So you're doing in the theater awake reduction patient as with the C I'm doing, and you're doing control traction and gentle rotation, and it reduces. That's good. You then you held it with the it's straight. The thing is here, see, here they may ask you, if it is unilateral dislocation, they may ask you, so this is bilateral, so is it difficult to reduce? It is easy. Bilateral is reduces easily, but it's redisplaces. It's difficult to maintain the reduction. Whereas unilateral is difficult to reduce, but once it's reduced, it's pretty stable. So that is the difference. That's they may expect and would like to see whether you're what's your depth of knowledge on it and your experience on it. So then once you reduce, either you reduce bedside, awake patient traction, reduce it, and if it's reduced over the night in a traction with the weight on it, allow weight traction, good, and you can plan in the morning about what needs to be done definitively. At least you've taken the pressure of it, you've reduced it a bit, and this is all in a you may be in a unit where you've taken the theater state, and you have the facilities, expertise and everything. So in a decent daylight time, hours, not odd and out of hours or whatever, then you taken to the theater, you've done a reduction, it's reduced, and you may want to do definitive stabilization. As I said, it depends on resources and facility. So once, so this is kind of a scenario. They might say the patient is, you don't want a patient is awake, but you don't want an MRI. Then you say, if the patient's neurology is intact, I don't need, I would try to reduce sooner. If the patient is obtunded, yes, you need MRI, no doubt. So if you're reducing, and if the neurology develops, you release the traction, release the pressure, position him and take for an MRI, and then proceed accordingly. So MRI is for awake patient, not needed straight away. You can attempt reduction. For an obtunded patient, yes, you need MRI. What do you are looking for an MRI? MRI, you are looking for whether there is any disc disruption, whether there is any disc protrusion, and what is the spinal cord status, whether there is any edema already, if there is much any hemorrhage or any significant any transaction, everything. And if the disc, if you have an anterior disc, then yes, you need to do anterior decompression and stabilization as well. And the question comes whether you go anterior first or posterior first. So I will come to that in a minute. So MRI, we have talked about timing of MRI. So the MRI should be done promptly in a, the patient is stable enough to go through the MRI in a obtunded patient. In an awake patient, you can attempt reduction and you can do it, at the earliest convenience. Once the reduction is done, you're happy, then you can do it. If the patient is a polytrauma, intubated and all, yes, you have to see the timing of MRI, because subjecting a ventilated tubed patient to MRI is more, increasing the mobility of the ventilation tubing and everything. So you assess the situation and then take it from based on your ICU guys and everything. So timing of surgery. See, as I said, timing of surgeries again is there's no clear consensus. Now people are saying within 24 hours early is best, and some are saying ultra early. Some evidence is coming up. So as I said, sooner is better. Again, here the concept is to help recover the injured cord, to enhance the recovery. Okay, so timing of surgery sooner. And again, they can say, you may say spine unit. Every time you cannot say spine surgeon, spine unit. Once they've said you're in the spine unit, you're a part of spine team, then you have to lead and go on accordingly. Okay, so there is a consensus that early decompression stabilization helps neurological recovery and the rehabilitation, enhanced rehabilitation. So as per our unit practice, and we will try to reduce within take him to theater as soon as possible. If he comes in the middle of the night, 12 o'clock, and if it's a recent hours, probably you can do it the first thing in the morning sooner. You alert, get everything ready, because whereby 2 o'clock, 3 o'clock is when the whole team had a long day or long shift. I think it is very sensible and to leave it for the first thing in the morning. Sometimes if in a decent hours like this, or you get a neurology 6, 7, 8 o'clock, 9 o'clock, 10 o'clock, team is ready, facilities there, yes, you can go sooner. So there is nothing. So 24 hours, yes, there is consensus and the more recommendation. The trend is going towards that. You may argue that in the literature there is no evidence the difference between 24 hours or those operated between 24 to 48 or beyond 48. But what is the best? The current trend is towards early. So that's you keep in mind. Again, here you got to pull in your spinal cord injury unit. And once you've done a stabilization, decompression, you will have to be in constant touch for the rehabilitation, because rehabilitation forms, the huge is going to be the game changer for his quality of life. So touch base and following their instructions, moving patient to there for a rehabilitation is all what needed. So you have to have our thoughts. Okay, stabilize, decompression as per our unit, what timing and everything, So timing of surgery you've done, and then they may ask you, so what do you want to do? As I said, anterior, posterior, 360. So if you come to this stage, that means you're 7 and 8. To stage 7, at least. So you're going to say yes. They are not expecting you all the technique tapes and everything. They are expecting that you've been in the situation, you've dealt the patient before. That's what they're expecting. And you know how to manage, even if you're not a spine, you're going to be doing foot and ankle or knee orthoplastic guy. If you get a spine patient under your, on your trauma call, and how you would manage, that's what they're looking for. That's it. So you say, okay, so this patient from look at it is some, if the disc MRI If there's no anterior disc protrusion, people will go from posterior. If there is an anterior disc, you go anterior, take the disc, decompress, and then do a posterior. So that's what anterior posterior, which is 360. Or some people will reduce just anterior and a collar, and may do posterior if needed in a staged. Or some people go anterior and posterior, same setting. It all varies. But the principle is people can reduce and stabilize from back if the disc is not disrupted. Posterior people will super alone sufficient. The disc is disrupted and there is a protrusion of the disc compressing your cord, then anterior and posterior. Then remember, your decompression and surgery is only the initial management part, comes as a part of initial management. The long-term management and everything is through spinal cord rehabilitation. So you have to make sure you spit out spinal cord injury center referral and guidance for the continued care. So some like Thracolumbar, you have some of the classifications. So basically, it's like upper cervical or subaxial ones, subaxials. So upper cervical is occipital cervical and the C1, C2. That's different eponine classification, and then you have a Alex Ferguson morphological classification, flexion compression and flexion distraction, extension compression types, and then you have AO spine, and then you have a subaxial, like Telix, you have a subaxial cervical injury classification. If you remember them, that's good. If you spit out, that's good. As I said, the examiner asking you may not be orthopod and you may not be aware, and you're giving a new information because all of the it is a standardized for exam. So the questions and the prompts, everything are standard. They can't ask random, on the same topic, they can't ask random question. So if you spit out something new that he has not learned it from other candidates, then it's at a brownie point for it. So just knowing these things will help. The last topic I want to touch base today is Cauda-Equina syndrome is another emergency. This is the T emergency that pops up. And they're very common. Common things are common. So you may be shown a flashcard with a disc, and so you may ask you, so what do you see? So you're going to see a sagittal and axial MRI where there's a L4-5 degen and a huge disc protrusion occupying almost 80 to 90% of the canal and the axial. Rest of the discs appear normal, healthy. And I would like to know the clinical features, because this huge disc is what you got. So this disc may be asymptomatic. They might have found it accidentally while doing imaging for something, or you might be having some simple radicular symptoms, or patient may be having more than a radicular symptom. So once you've seen the image, you know to know the more history. I need to know more history and know about the patient's symptoms. Then they may give you more hint that this is a patient with leg symptoms